latent TB in pregnant women and children. So Dr. Mathad is an assistant professor in medicine and obstetrics and gynecology at the Center for Global Health at Weill Cornell Medical College in New York. Her primary research interest is in the immunology changes of pregnancy and how this can affect the development of TB in TB endemic countries. I think that's a very unique field and not many people focus on that, so thank you for looking into that. She is an investigator and notably in the IMPACT network, she has led the IMPACT 2001 study looking at 3HP in pregnant women. So welcome, Dr. Mathad.
Thank you. Thanks for the introduction, and thank you for inviting me to talk today about TB in pregnancy and in children. I think with children, as I'll go over, there's a lot of good data to suggest that they're a high-risk population. Pregnant women are often left out of a lot of these things, so I will take a second to try to convince you that they're also a high-risk population, but I really commend the organizers of this to focus on these populations that are sometimes neglected in research. So we've seen this a ton of times where there's 10 million new people who are diagnosed with active TB every year, and the majority of them do tend to be men, but you can see that there are 3.2 million and 1 million of women and children respectively that are infected. And we all, like I said, understand that the young children are especially at high risk of going from infection to disease. An area where we don't really understand is pregnant women. There's no national or international programs that systematically collect data on how many pregnant women have active TB, and so we don't really know what the burden is in pregnant women. There was a study that was done a couple of years ago that was a modeling study that basically looked at all the statistics we have and came up with a number around 260,000 women that have active TB while they're pregnant. But again, this was based on modeling and not actually based on epidemiologic interviews. So it's important for us to try to think about that when we're trying to understand the burden of disease in pregnancy. But there is reason to think that pregnant women are at high risk, and there are epidemiologic studies done in the UK where they followed almost 200,000 women for 9 years throughout their entire lives. And what they found was that the highest risk time for women in general to develop active TB was around the time of pregnancy. In fact, within the first 3 months postpartum, their risk was double that it was any other time in their lives. And so that's some epidemiologic data from at least one country. And there's some reason that we can think immunologically why that might happen. So during pregnancy, there are all these complex immune changes that are happening during the pregnancy, and a lot of this is so that the woman can tolerate the fetal foreign antigen that's growing inside her body. But some of the cells decrease, some of the cells increase, and I'm not going to go into great detail, although I would love to, but you can ask me about that later. But some of these changes can increase the risk of infections, and we know that pregnant women are more likely to get listeria, for example, or they're more likely to get severe forms of influenza. We don't exactly know how these immune changes interact with TB, and that is the focus of a lot of my research, but there's reason to suspect that if there's lower CD4 cells and NK cells, which we know are important for TB pathology, that would perhaps increase the risk of a woman progressing from latent TB infection to disease. In the area of infant disease, obviously, this data is much more sound, and we know for sure that in this graph you can see the pulmonary TB in the blue bars and the disseminated TB in the orange bars. And we know that the younger children, because their immune systems are not developed well, are at the highest risk of developing active TB. So even if you don't fully believe all of the data about pregnancy, with the infants we have strong data for that. And if there's a great way to prevent TB in infants, it would certainly be focusing on their mothers. So another reason that we should worry about TB in pregnant women and children is because when they get TB, very bad things happen. And I won't go through the entire list in the interest of time, but do focus on the fact that if you do develop active TB while you're pregnant, your risk of dying is way, way higher than it would be otherwise. In HIV uninfected women, the risk is 25 times greater, but in HIV infected women, it's 37 times higher than if you just have HIV alone. And when they're infants develop active TB, they also have a myriad of bad outcomes that can happen, including potentially an increased risk of getting HIV from their mothers. So if a woman has HIV and TB when she has her baby, that infant might be more likely to contract HIV from its mother. And again, that the infants are more likely to die if they have active TB. And there's data even to suggest beyond infancy that if a child lives in a home with a mother that has active TB, their risk of death in general is about 8 times higher. healthcare. So again, if you don't necessarily believe in the preventive therapy for pregnant women for their health alone, certainly it's a good way to intervene to prevent infant infection and disease. So the big question is really, who should we treat and what should we be treating them for? And that's really what I'm going to focus the rest of my talk on. So for pregnant women, there are slightly different recommendations in terms of when we treat them with TB preventive therapy. So in low-burden countries, the focus is primarily, actually in low and high-burden countries, the focus is primarily on HIV-infected women, and that's because we understand that there is a higher risk in HIV-infected than uninfected women. For the WHO, we all know the recommendations that said that anyone with HIV should get TPT, and that's regardless of their IGRA or TST results, and that includes pregnant women. But the issue is that even though they made that recommendation a few years back, a lot of countries haven't really moved towards implementing that because there's concern about the safety of giving INH during pregnancy, and that was really based on some pretty old data from the 1980s, a retrospective study that suggested that pregnant women who got INH might be higher risk of getting hepatotoxicity or of dying from liver failure. And so everyone got very scared about it, and everyone tried to defer treatment until after pregnancy, 3 months after pregnancy. But there are data to suggest that women who can take INH during pregnancy and it's okay. We heard some data from Dr. Howard from Eswatini. There's also data that Sylvia LaCourse and others have provided in Kenya where they looked at HIV-infected mothers and asked them if they had ever been on IPT at any time, and it turned out that not only had they been on IPT, but that a vast majority of them, almost 92% of them, had completed IPT therapy. So there is not that concern of implementation adherence. There was a high rate of adherence to it. And interestingly, if you look at when the women took the IPT, almost 50% of them took it during pregnancy itself. So when we're concerned about giving medications in pregnancy, the women themselves are okay taking some of these medications. And within pregnancy, almost 50% of them initiated during their first trimester. The median gestational age was 15 weeks. So it does suggest that in terms of scaling up, that the antenatal period is a good time to interact with women. They come to us anyways to see us for healthcare, and it might be the right time for us to start integrating IPT into care. There was no randomized control data about the safety of isoniazid until recently. And I think the study, TB Apprise or P1078, done through the Impact Network, really emphasized the importance of why we need to do research in pregnancy. So this was basically taking the question that I posed, which is, should we give IPT during pregnancy or should we wait until 3 months postpartum? And they did a randomized control trial doing just that. And they enrolled over 950 women from 8 different countries. And in a nutshell, the result was that it didn't really make a difference in terms of hepatotoxicity or hepatotoxic events, whether or not you took the medication during pregnancy or after. However, there was data to suggest that there might be an increased risk of adverse outcomes. So there was, if you look at the composite score, there was a significant difference. But as you can see on the chart, that the main differences seem to be driven by differences in low birth weight and differences in fetal demise. And so this raised the question of whether or not we should be giving IPT during pregnancy because there is this potential risk of increased adverse outcomes. On the other side, though, if you looked at women in either arm, women who had received medication during pregnancy or started postpartum, that both groups of women actually had an increase in ALT, which is what this graph is showing you, between delivery and 3 months postpartum. And we don't know exactly why that happens, whether that's just a normal thing that happens, that was an effect of, they were mostly on efavirenz-based regimens, but it seems to happen. So, is 3 weeks or 3 months postpartum when their ALT is at their highest, the time when you want to start INH or rifapentine or other medications that go through the liver? Perhaps that's not the right timing either. So, that's why we do the research, though, right, to answer these questions and sometimes get more questions. So while we're figuring out what to do with that, and I think the WHO is trying to figure out what to do with that in their guidelines that are coming out soon, the good news is that we have some more data, and Dr. Chasen mentioned this earlier, but through Impact, we're also doing a study on 3-HP in pregnant and postpartum women, and we enrolled women in their second trimester as well as their third trimester and followed them longitudinally, though, so we can see how the gestational age impacts the way the drugs behave in the body. And also we included HIV-infected and uninfected women, so hopefully when this data is ready by the end of probably September, October, we'll be able to make some comment on whether or not 3-HP is an appropriate regimen for pregnant and postpartum women. Other stuff that's in the pipeline is a concept that we've put forward to look at 1-HP and 3-HP in pregnant and postpartum women. It's proposed to be a large study, and it's somewhat complicated, but we do think that it would answer all of the questions. It would answer the questions of which regimen is the right one to give, since all of us understand that taking daily isoniazid is hard to adhere to, and it would also answer the question of when is the right time to give medications to pregnant women, whether it's during pregnancy or postpartum. So that's also in the pipeline. Hopefully we'll move forward soon. So just to switch to children, so again, like I said, the data for children, there's more consensus around this, so most people agree that if you are less than 5 years old and you live or have close contact with someone with active TB, you should get latent TB treatment, and of course making sure that they don't have active TB. Some countries suggest IGRA or TST, but as we heard earlier this morning, sometimes that is an additional hurdle, and if that doesn't need to be done, then don't do it. The main medications, again, similar to pregnancy that we've used in children is primarily isoniazid because that's the only medication that we had data for. But recently the CDC changed their recommendation to now include the 3-HP regimen for children over 2 years old. And that was primarily based on the pediatric sub-study from PREVENT, which looked at children from 2 to 11 years old, and they were basically just comparing the pharmacokinetics, so saying, do we get the same level of drug in children if we give them this medication as we do in adults? And what they did is they did a weight-based regimen, so you can see the weight bands there, and you can see on the right side that generally the weight corresponded with the age of the patients, and so they would decide the dose based on this. So what you can see here is on the left two panels are the levels for the children, and the rightmost is the one for the adults. So you can see that the children do achieve similar levels to the adults, but the difference between those two panels in the beginning is the whole pill created higher levels of the rifapentine than the crushed pill did. So this again emphasizes the importance of doing studies in children, because in children they don't just take a pill the way adults can. A lot of times you do have to crush the medication, and understanding how crushing the medication changes the way the drug behaves in the body is important. So just to keep in mind that that's a difference. There's much more variability once you crush the drug. So based on that now, if you look at the package insert for rifapentine, you'll see that the FDA has approved this kind of regimen where you don't have to look at this for too long, but basically it gives you age and then percentile of weight, and so based on that you can figure out what's the appropriate dosing for a child. And then notably, those studies all started with children at 2, and so we don't know what to do in children less than 2. And as I showed you earlier in the presentation, the children less than 2 are actually the most highest risk group. So TBTC study 35 is a study that is going to do dose finding for 3-HP in children, and they started with the first 2 cohorts, which are the older children, but then they will move into younger children, 1 to 2 and 0 to 1, to figure out what's the appropriate dosing for each of those age bands. And they'll be doing real-time intensive PK sampling and pharmacometric modeling, so hopefully they'll be able to comment on whether or not fixed dose combinations can be made for these regimens in small children. Other exciting stuff coming down the pipeline for children, similar to Concept 5021 that's in pregnant women. There's also Concept 5019 also being pushed through IMPACT right now, and that's a dose-finding study for the 1-HP regimen, and that will include children less than 15 years. And then there's also, and I'm not going to steal Dr. Churchyard's thunder because I know he comes right after me, but there are some studies coming up to look at preventive therapy for children who've been exposed to people with MDR-TB, and what are we supposed to do with that? So Phoenix and TB Champ are 2 of those studies that have included children, which is, I applaud those 2 groups for making the point to include children. Unfortunately, pregnant women are not included in either of those studies, but hopefully one day we will have data on that as well. So just to summarize, pregnant women and children, I think, are at high risk of progressing to active TB disease. Currently, the recommendation for pregnant women is mainly focused around the INH regimen, but we don't really know how the results from the 1078 study will change guidelines, and hopefully in the next few years, this year and in the next few years, we'll have data on the 3-HP regimen and the 1-HP regimen, which seems to be where the rest of the world is heading as well. For children, right now, if you're over 2, at least per CDC recommendations, you can receive INH or 3-HP. I think, again, the 3-HP regimen is going to be reviewed by WHO and hopefully would be included going forward. And then data on children less than 2 is forthcoming, and then we should hopefully have data on 1-HP and MDR-TB. And just as my final soapbox statement, it's exciting to me to see that we've started to include pregnant women and children in some of these studies a little bit earlier. I think in our HIV experience, we left pregnant women on AZT-based regimens for far too long, and now we've really expedited how quickly we start to include pregnant women in our antiretroviral trials, and I think there's a lot to be learned from that in the TB world to try to figure out ways to include them earlier so they're not on older regimens that are harder to take and more toxic because we're just too scared to study them. So hopefully we'll have a lot more data on that in the coming years. Thank you so much for your attention.